Bismillahirrahmanirrahim. Assalamu alaikum. Welcome back. In today's lecture, we will be exploring the fascinating physiological changes that occur in the body during Ramadan fasting. From metabolism shifts to hormonal adaptations, fasting triggers a series of responses that impact energy levels, hydration, and overall health. Understanding these changes can help us maximize the benefits of fasting while staying mindful of our well-being. Stay tuned as we break down the science behind Ramadan fasting. As mentioned in the intro, today we shall see the physiological changes in the body during fasting, and then we will see how these changes behave in the patients with liver cirrhosis. In the start of this workshop, I have discussed with you that this workshop has got 5 sections. Today we are in the second section of this workshop, physiological changes during fasting. And as mentioned, these physiological changes can be divided into 3 main components: the metabolic changes, the fluid and electrolyte balance, and hormonal changes. In the metabolic changes, it's a shift from glucose to ketone metabolism and implications of liver functions. We shall see this in our lecture today. Then in the fluid and electrolyte balance, there's a risk of dehydration and electrolyte disturbances, particularly in patients with liver cirrhosis. And the third aspect is the hormonal changes. We'll see there's the impact of fasting on hormone levels, including insulin, glucagon, and cortisol, and how they impact patients with liver cirrhosis. The metabolic changes, as mentioned before, during fasting, the body undergoes significant metabolic changes as we see shift from glucose to ketone metabolism. The ketone metabolism is active and the glucose metabolism is temporarily a bit suppressed. So there's a great shift from the glucose metabolism to the ketone metabolism. This shift can lead to changes in liver function, including increased ketone production and reduced glucose output. The second aspect or component is that of the fluid and electrolyte balance. Fasting can lead to dehydration and electrolyte disturbances, particularly in individuals with liver cirrhosis. The liver plays a critical role in maintaining fluid and electrolyte balance, and impaired liver function can exacerbate these disturbances. The third aspect or component is that of hormonal changes. Fasting can also lead to changes in hormone levels, including insulin, glucagon, and cortisol. These hormonal changes can have significant effects on liver function and glucose metabolism. So what are these physiological changes during cirrhosis? In a cirrhotic patient, there are physiological changes, and then with patient with those changed physiological mechanisms, when that patient fast during Ramadan, so these changes pose its peculiar challenges. Cirrhosis leads to a cascade of physiological changes affecting multiple organ systems due to progressive fibrosis, vascular remodeling, and hepatocellular dysfunction. These changes are primarily driven by portal hypertension, systemic inflammation, and metabolic derangements. These changes include hemodynamic and cardiovascular changes. Second, renal and fluid homeostasis changes. Third, metabolic and nutritional changes. Fourth, neurological changes. Fifth, immune system changes. Sixth, gastrointestinal changes. Seven, endocrine and hormonal changes. So we will discuss these changes in detail one by one in the same sequence. First, hemodynamic and cardiovascular changes. What are the different hemodynamic and cardiovascular changes during cirrhosis, irrespective of the Ramadan during cirrhosis? These are, there's portal hypertension. It means there's increased intrahepatic resistance and splanchnic vasodilatation. This portal hypertension is the result of increased intrahepatic resistance and splanchnic vasodilatation. There's hyperdynamic circulation, and this is because of increased cardiac output, low systemic vascular resistance, and arterial hypertension. Then there's the cirrhotic cardiomyopathy. There is blunted myocardial contractile response to stress, diastolic dysfunction, and prolonged QT interval. And then there is hepatopulmonary syndrome, that is the pulmonary vasodilatation leading to hypoxemia and apletypnia, orthodeoxia. And then there is portopulmonary hypertension, that is pulmonary arterial hypertension due to increased pulmonary vascular resistance. So the hemodynamic and cardiovascular changes in liver cirrhosis. On the liver side, there's increased intrahepatic resistance, and in the lungs also there is pulmonary arterial hypertension because of the increased pulmonary vascular resistance. This portal hypertension, it is because of two main reasons. One is the splanchnic vasodilatation because of that nitric oxide disbalance, and there's intrahepatic resistance is increased, and this leads to portal hypertension. And then we see the hyperdynamic circulation. This is because of the increased cardiac output, and there is low systemic vascular resistance and arterial hypotension. We do see the cirrhotic cardiomyopathy and the hepatopulmonary syndrome. So all these are the five main changes in the hemodynamics and cardiovascular system which we see in a cirrhotic patient. This is irrespective of the Ramadan in a cirrhotic patients. The second is that of renal and fluid homeostasis changes. What are these? These include sodium and water retention due to increased renin-angiotensin-aldosterone system activation and vasopressin release. Second, there is hyponatremia due to dilutional effect of water retention. Then there is hepatorenal syndrome. There's a risk of that. That is the functional renal failure due to renal vasoconstriction and reduced renal perfusion. And there's impaired acid-base balance because of it, and it leads to increased risk of metabolic acidosis from renal dysfunction. So these are the four main renal and fluid hemostatic changes what we see in a cirrhotic patients: sodium and water retention, hyponatremia, hepatorenal syndrome, and impaired acid-base balance. Going into somewhat detail of the metabolic and nutritional changes what we see in the cirrhotic patient, these includes glucose metabolism. First, there is insulin resistance, which leads to hepatogenous diabetes. There's decreased gluconeogenesis, leads to hypoglycemia in advanced stages, and there is reduced glycogen storage. So on the glucose metabolism, we see these three, it has got these three components: insulin resistance, decreased gluconeogenesis, and reduced glycogen storage. Then on the lipid metabolism, we see reduced lipoprotein synthesis, which leads to altered cholesterol metabolism. And on the protein metabolism, there's increased muscle catabolism due to impaired protein synthesis, and it leads to sarcopenia and frailty. And there is micronutrient deficiencies, which specifically are the most common are the deficiency in vitamins A, D, E, K, that is the fat malabsorption, and zinc and magnesium deficiencies, which contribute to hepatic encephalopathy. So on the metabolic and nutritional changes, these has got four important components: the glucose metabolism derangements, lipid metabolism derangements, the protein metabolism derangements, and micronutrient deficiencies. In the glucose metabolism, we see the three main changes: insulin resistance, which leads to heterogeneous diabetes, then the decreased gluconeogenesis, which leads to hypoglycemia in advanced stages, and reduced glycogen storage. And the lipid metabolism, as said, there's reduced lipoprotein synthesis, which leads to altered cholesterol metabolism. And on the protein metabolism side, there's increased muscle catabolism due to impaired protein synthesis because the liver is faulty, so the sarcopenia and frailty. And in the micronutrient deficiencies in vitamin A, D, E, and K, which leads to fat malabsorption, as well as there's zinc and magnesium deficiencies, which contribute to hepatic encephalopathy. What are the neurological changes which we see in cirrhotic patients? There's hepatic encephalopathy. We know that the well-known complication, a combination of ammonia and neurotoxic substances, which leads to cognitive dysfunction, confusions, and even coma. Then autonomic dysfunction leads to impaired baroreceptor response, leading to orthostatic hypotension. And this becomes problem when the patient is on beta blockers, especially carvedilol. Sleep disturbances and mood disorders due to altered neurotransmitter metabolism and melatonin dysregulation. So in the neurological changes, there are three main: the hepatic encephalopathy, autonomic dysfunction, and sleep disturbances and mood disorders. On the immune system changes, what we see: cirrhotic immune dysfunction syndrome, CIDS. It's a combination of immune deficiency, that is the impaired phagocytosis, complement dysfunction, and systemic inflammation, that is the activation of the monocytes and macrophages. So we see the cirrhotic immune dysfunction syndrome, which has two components. So on one side, there's impaired phagocytosis and complement dysfunction leading to immunodeficiency, and there's systemic inflammation. It is because of the activation of the monocytes and macrophages. So it's an imbalance, or this is a dysfunction syndrome. Second is the increased susceptibility to infections. Spontaneous bacterial peritonitis, pneumonias, UTIs, these are very common in cirrhotic patients, and this is because of this immune system changes. And the third is the endotoxemia and systemic inflammation. And this is because of bacterial translocation from the gut, exacerbating inflammation and multi-organ dysfunction. So these are the three main immune system changes: cirrhotic immune dysfunction, increased susceptibility to infections, and endotoxemia and systemic inflammation. Coming to the sixth are the gastrointestinal changes. What are these? There's esophageal and variceal, gastric varices due to increased portal pressure. We see the gastroparesis and delayed gastric emptying, which is because of the autonomic dysfunction affecting mortality. And there's a small intestinal bacterial overgrowth, SIBO, which contributes to endotoxemia. And there's altered bile acid metabolism, leads to fat malabsorption and steatorrhea. So there are four main GI changes: esophageal gastric varices, gastroparesis and delayed gastric emptying, small intestinal bacterial overgrowth, and altered bile acid metabolism. And coming to the seventh one, that is the endocrine and hormonal changes, what we see: hypogonadism. There's a low testosterone in men, and there we see the menstrual irregularities in women. There is adrenal insufficiency due to impaired steroidogenesis, and there is thyroid dysfunction, low T3 syndrome, euthyroid 6 syndrome. This is also seen in cirrhotic patients. So on the uh, endocrine sides, three main changes: the hypogonadism, altered adrenal insufficiency, and thyroid dysfunction. So any cirrhotic patient, depending upon the stage of the cirrhosis, they are having all these seven physiological changes. And when a patient with having these seven physiological changes, that patient fast, definitely that the fasting brings some unique risks and challenges. So in the next section, we shall discuss in the next vlog the risks and complications of fasting in liver cirrhosis, because we understood today that any cirrhotic patients, they do have these physiological changes, at least seven types, and we explain each and every type in detail, what are the subcomponents of those physiological changes. So if a cirrhotic person fast, what these changes bring risk and complication. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome back to the channel. In today's lecture, we shall be discussing the risks and complications of fasting during Ramadan for individuals with cirrhosis. While fasting has spiritual and health benefits, it can pose serious challenges for those with liver disease. We shall explore how cirrhosis affects the body's ability to adapt to fasting, the potential risks involved, and important medical guidelines to ensure safety. Stay tuned for expert insights on managing cirrhosis during Ramadan. Section 3 of our workshop, Risks and Complications of Fasting in Liver Cirrhosis. These are the 5 sections of our workshop, and today we shall cover section 3, 4, and 5. Section 3 of our workshop, that is the risks and complications of fasting in liver cirrhosis, has 4 main aspects: dehydration and electrolyte imbalance, hepatic encephalopathy, variceal bleeding, and worsening liver functions during Ramadan fasting. The first component, that is the dehydration and electrolyte imbalance. Individuals with liver cirrhosis are at increased risk of dehydration and electrolyte disturbances during fasting. In the previous video, we discussed the physiological changes in a cirrhotic patient, and in keeping that in view, now we are discussing the impact of fasting on physiological aspects of a cirrhotic patient. So individuals with liver cirrhosis are at increased risk of dehydration and electrolyte disturbances during fasting. This can lead to complications such as hepatic encephalopathy, variceal bleeding, and worsening liver function. The second component is the hepatic encephalopathy. Fasting can exacerbate hepatic encephalopathy. That's a complication of liver cirrhosis characterized by cognitive impairment and altered mental status. The third challenge is that of variceal bleeding. Fasting can increase the risk of variceal bleeding, a life-threatening complication of liver cirrhosis. We know that. And the fourth is the worsening liver function. Fasting can worsen liver function in individuals with liver cirrhosis because the liver functions are already compromised in cirrhotic patients, particularly those with advanced disease. Section 4 of our workshop is the precautions and recommendations for fasting in liver cirrhosis. And here we will discuss the pre-fasting evaluation of cirrhotic patient, hydration and electrolyte management in such patients, managing, monitoring and follow-ups during Ramadan, and alternative fasting options. Pre-fasting evaluation is important. Individuals with liver cirrhosis should undergo a thorough pre-fasting evaluation, including assessment of liver function, electrolyte levels, and overall health status. Child peak and MELD scores are very important to determine the severity of cirrhosis, and they should be calculated. Hydration and electrolyte management. Individuals with liver cirrhosis should be advised to drink plenty of water and electrolyte-rich fluids during fasting to minimize the risk of dehydration and electrolyte disturbances. So, from iftar to suhoor time, if they are fasting, then they need to take care of their hydration and electrolyte imbalance when they are not fasting, when the fasting hours are paused. So during that, they need to take care of their hydration. Monitoring and follow-up. Regular monitoring and follow-up are essentials to detect potential complications early and provide prompt treatment. So if a cirrhotic patient is fasting during Ramadan, her regular monitoring and follow-ups are essential. Alternative fasting options. We must educate and we must present to them the alternative fasting options. Individuals with liver cirrhosis may need to consider alternative fasting options, such as shorter fasting periods. Shorter fasting periods are exemptions from fasting to minimize the risk of complication. So, by shorter fasting periods, I mean that they may keep fasting on one day and fasting on the alternate days, so they give the break among two fasts. This is one of the possibility, and the day when they are not fasting, then for that day they give the fidya, or the 1 out of 3 days they fast, and the remaining 2 days they give the fidya, so they can do that way. It is not possible that they fast for shorter time. The fast has to be from the suhoor to iftar, but they can skip the days in that way. This is one of the possibilities. Or if they are unable to fast, then they give fidya with this intention that when they gain the health, they will keep the fast. In compensated cirrhosis, some studies suggest that fasting may be feasible under close monitoring. Regular checkups to monitor symptoms and lab parameters, they are very, very important. To monitor glucose, electrolytes, and hydration. We should emphasize balanced meals during suhoor and iftar, and encourage adequate protein and calorie intake, and adjust medications, diuretics to avoid adverse effects, and to assess diabetes, renal functions, and cardiovascular health. All these points we have discussed in our case histories when we were discussing our case histories in our second episode. In decompensated cirrhosis, if a patient is decompensated, it's a strong contraindication due to higher risk of complications, and we should provide a medical report to accept the patient. This is important that we should give them in writing, and of course We tell them, we educate them on the alternative options available. Our religion, Islam, does allow that if a patient is sick or critically sick, he or she may give fidya in the place of fasting. The fifth section of our workshop is the conclusion and future directions. And this is three components. We'll summarize the key points. What are the future research directions and what are the clinical implications? Summary of key points are that fasting during Ramadan can pose significant risks for individuals with liver cirrhosis, including dehydration, electrolyte disturbances, and worsening liver function. Pre-fasting evaluation, hydration and electrolyte management, and regular monitoring and follow-ups are essentials to minimize the risk of complications for cirrhotic patients during Ramadan. The future research directions are that the future research is needed to better understand the effects of fasting on liver function and to develop evidence-based guidelines for fasting in liver cirrhosis. The clinical implications are that healthcare providers should be aware of the potential risks and complications of fasting in liver cirrhosis and provide individualized guidance and care to minimize the risk of adverse outcomes. And this is the purpose of our workshop as well, to enable you to properly evaluate the individuals, the cirrhotic patients' status, and give your individualized guidance to them. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome back. In today's lecture, which is the last one of the workshop, we shall be discussing key guidelines for managing cirrhotic patients during Ramadan fasting. Fasting can pose significant challenges for individuals with liver disease, and proper management is essential to ensure their safety. We shall cover important medical considerations, risk assessment, dietary recommendations, and when fasting may not be advisable. Stay tuned for expert insights on how to navigate Ramadan safely for cirrhotic patients. Today is the last lecture of our workshop, and we shall discuss the key guidelines for managing cirrhotic patients during Ramadan. The guidelines on the management of cirrhotic patients during Ramadan. Managing cirrhotic patients during Ramadan requires a careful balance between respecting their religious practices and ensuring their health and safety. Physicians should provide individualized recommendations considering the severity of the liver disease, coexisting conditions, and overall patient health. And this workshop has been an attempt to ensure that the proper decision is made for the patients, keeping the severity or status of the health of a cirrhotic patient, and of course the religious obligations and requirement of Ramadan. These guidelines, they have dedicated sections. They are about what should be the pre-Ramadan assessment of these patients. What about the patient education and counseling? Fasting guidelines based on disease severity. If a patient is compensated cirrhosis child class A or decompensated cirrhosis child class B or C. Then, of course, the hydration and nutrition strategies. What about the regular monitoring during Ramadan of those patients who fast? When to advise cessation of fasting? And what should be the post-Ramadan care? So these guidelines, they have dedicated sections, and we will review these guidelines under these headings. First, the pre-Ramadan assessment. The pre-Ramadan assessment has different components. First, to evaluate liver function. Second, to do the nutritional assessment of these patients. Then to look for the coexisting conditions. To evaluate the liver function, you need to do the liver function tests. Assess for any signs of decompensation like elevated bilirubin, ALT, AST levels. Calculate the Child-Pugh score. This score A, B, or C helps classify the severity of cirrhosis. We know that. Patients with child class C or decompensated cirrhosis should be advised against fasting. Then the MELD score, calculate this, the model for end-stage liver disease. It's useful for assessing prognosis and risk for complications. Regarding the nutritional assessment of these patients, assess for malnutrition or sarcopenia. Patients with poor nutritional status should receive nutritional support before Ramadan. Weight loss and fluid retention. Determine if the patient has any signs of ascites or edema. And then the coexisting conditions, that is the third component of pre-Ramadan assessment of cirrhotic patients. Diabetes mellitus. Cirrhotic patients with diabetes may experience fluctuations in blood glucose levels during fasting. Their diabetes management plan must be adjusted. Hypertension and cardiovascular health. Control of blood pressure is essential for prevention of complications during dehydration. Now, the second component of these guidelines, that is the patient education and counseling. This comprises health risks for fasting for cirrhotic patients, how to educate them on those, and to educate them on self-monitoring and early warning signs. We should explain to them the health risks of fasting for cirrhotic patients, explain the potential risks of fasting, including dehydration, hypoglycemia, hepatic encephalopathy, and electrolyte imbalances. Tell them that these are the particular risks which they can have. And then inform patients of the exemption. Tell them that the Islam has provision for those who are ill or have chronic conditions. And it allows them to either break their fast or compensate by feeding the poor. If the patient is fasting and the condition worsens, so he or she can break the fast, and even they can avoid the fast on the subsequent days and giving fidya. What about the self-monitoring and early warning signs? Encourage the patients to monitor themselves for symptoms such as dizziness, confusion, weakness, fatigue, dark urine, or signs of dehydration. If they develop these, then they may break their fasting or they may avoid the fasting. Advise patients to break the fast immediately if these symptoms occur. Now, the third component of these guidelines is on the fasting guidelines based on disease severity, but for those who are having compensated cirrhosis. It has the subcomponents of possible to fast with monitoring, and dietary guidelines, and of course, the medication adjustments and monitoring of such patients. So, the possible to fast with monitoring, there is an option for these patients. Patients with stable compensated cirrhosis, that is Child-Pugh A, may be able to fast with close monitoring, especially if they are not experiencing ascites, encephalopathy, or severe malnutrition. What about the dietary guidelines to these patients? In the suhoor, that is the pre-dawn meal, they should have high protein, high complex carbohydrate diet, and fiber rich foods to maintain energy levels throughout the day. They should avoid salty foods in the suhoor. In the iftar, that is the breaking the fast, they should have balanced meal with adequate protein, carbohydrates, and healthy fats. And they should ensure good hydration with water and electrolyte rich fluids during the time period between iftar and suhoor. And they should avoid heavy greasy foods. The third component of fasting guidelines on disease severity is about the medication adjustment. Ensure medications that affect liver function, such as diuretics and lactulose, are properly timed, typically after iftar. Adjust doses of diuretics if needed to avoid dehydration and carefully monitor renal function. Regarding the monitoring, blood glucose monitoring should be done. Check glucose levels, especially for patients with diabetes. Modify insulin or oral hypoglycemics as necessary. Electrolyte levels. Monitor for electrolyte imbalances, especially potassium and sodium, and correct as needed. The decompensated cirrhotic patients, what are the fasting guidelines for them? Again, there's a statement that strongly advise against fasting. Alternative recommendations you should offer them, you should tell them, you should educate on them. And of course, managing decompensation risks. Decompensated cirrhotic patients, child class B and C, involves complications such as ascites, jaundice, varices, and encephalopathy, making fasting risky due to the high risk of dehydration, electrolyte imbalances, and worsening liver function. So if your patient has got any of these complications and he or she is in child class B or C, then strongly advise against fasting. The alternative recommendations, you educate them, you tell them that there is exemption from fasting, advise patients not to fast, and reassure them that they are not breaking their religious obligations. They can compensate by feeding the poor or fasting at a later time with their health. When their health improves, they should give the fidya. Managing decompensation risks. Optimize diuretic therapy to manage ascites and edema. Ensure lactulose is properly treated to prevent hepatic encephalopathy. If they present with these complications to you, it's a standard protocol. Follow the standard protocol. Monitor for renal dysfunction, hepatorenal syndrome, and consider withholding diuretics if renal functions declines. The fourth component of these guidelines, these are the hydration and nutritional strategies. And this includes fluid intake, electrolytes balance, meal planning. In the fluid intake, instruct patients to drink at least 2 to 3 liters of fluids during non-fasting hours between iftar and suhoor to prevent dehydration. If cirrhotic patient is fasting, so this is very important, encourage the fluid intake. For patients with ascites or edema, hydration should be monitored to avoid exacerbating fluid retention. And of course, when they have got these complications, we advise them not to fast. Electrolytes balance. Encourage the intake of electrolyte rich fluids like oral rehydration solutions or coconut water to prevent hyponatremia, which can worsen hepatic encephalopathy. If these patients they are fasting, they were in compensated cirrhosis, and you allowed them to fast. Adjust diuretic therapy if the patient is prone to electrolyte imbalance. Meal planning in the Sahar should include low digestive foods, that is, the whole grains, legumes, to maintain energy and reduce hunger during the day. In the Iftar, focus on a balanced meal with proteins, vegetables, and complex carbohydrates. Avoid high fat, high sodium foods that may exacerbate ascites or hepatic function. The fifth component of these guidelines is about regular monitoring during Ramadan, and it includes close follow-ups, blood glucose managements, assessment of ascites and encephalopathy. The close-up follow-up arrange for regular follow-ups appointments during Ramadan to monitor liver functions, electrolyte levels, blood glucose, and nutritional status if these patients are fasting. Frequent blood tests every 1 to 2 weeks to assess liver functions, renal functions, liver functions, electrolytes, and any signs of decompensation. Regarding blood glucose management, monitor blood glucose more frequently for diabetic patients, especially those on insulin or oral hypoglycemics. Adjust medication doses to avoid hypoglycemia. Regarding assessment of ascites and encephalopathy, check for signs of worsening ascites or the development of hepatic encephalopathy. Of course, this is a group when you advise them not to fast, but as we discussed in our case histories, some of them may fast despite your advice. So this is mostly for those patients. If either is noted, advise cessation of fasting. The sixth component of the guidelines is when to advise cessation of fasting, when you should tell them. What are the clear-cut criteria for that? The immediate fast cessation is required when the patient develops signs of dehydration like dark urine, dizziness, or fatigue. If the patient get confusion or altered mental status, that is the signs of hepatic encephalopathy. If there are electrolyte disturbances or severe fluid imbalances, or if there is severe hypoglycemia or hyperglycemia that cannot be managed. So if these conditions are present, you advise immediate cessation of the fast. Alternative religious practices, of course, if the patient is unable to fast, advise compensating through fidyas, that is feeding the poor, or making up for the fast after Ramadan when their health allows. Emphasize that Islam provides flexibility for the sick, and not fasting is allowed in case of medical necessity. The seventh component of these guidelines is on the post-Ramadan care. Monitor for decompensation. If the cirrhotic patients have fasted during Ramadan, this is very important for them. After Ramadan, closely monitor for any signs of liver decompensation, such as fluid retention, jaundice, or encephalopathy, and adjust medications accordingly based on post-Ramadan health status. Nutritional support. Provide additional nutritional counseling to help patients regain any lost weight or improve their dietary habits after fasting. So the guidelines on the management of cirrhotic patients during Ramadan has these 7 components, and each component has its own sub-aspects. And we need to cover all these. We need to be aware of all these to give the proper advice to such patients. So, dear colleagues, dear PGs, dear students, in a conclusion, the takeaway points are that for cirrhotic patients, fasting during Ramadan must be approached cautiously with individualized advice based on the patient's liver function, general health, and religious needs. Physicians should educate patients on the risks, monitor their health closely during Ramadan, and provide appropriate guidance to ensure safety while respecting their spiritual practices. With this, I pay thanks to all of you for being with me during these workshops. I hope I was able to uh, educate you on the different aspects of the issue uh, that in cirrhotic patients, what are the physiological changes which we see in any cirrhotic patients, and what are the physiological changes in Ramadan in a normal person, and when a cirrhotic person fast, how these physiological changes uh, they pose the complications, the challenges, and how we can implement that uh, clinically, apply that knowledge to advise them to fast or not to fast. And when they are advised, should be based on the data and the real world data. And because without having that data at the back of our mind, if we advise them in the wrong way, this is not only risk for their health, this is also a guna. So I'll request you to share these videos, these workshops to all of your colleagues, all of your juniors, all of your comrades. So the best possible care is extended to cirrhotic patients during Ramadan, and those who want to fast, they should fast, but if medically allowed, and if the close monitoring is warranted, and if it's going to be deleterious for those cirrhotic patients who want to fast but their health doesn't allow. So you properly counsel them, you properly educate them, and then they don't fast and go for the alternative options. So I end here. Inshallah, see you in another workshops. Till then, take care. Khuda Hafiz.